log into, try to see if it's
Yeah, they're
found a
attending the
sound system.
citizens. They're here, but they don't get the board
Yep,
privileges.
okay, it
as
looks like
citizens.
it connected, so.
That's my understanding anyway.
All right, disregard.
So, yep.
All right.
Ricky's was like that. Tell me when you settle, and we will come. Whenever you settle. All right. Good morning, everyone. We will call to order the September meeting of the Douglas County Board of Health. For the record, I do have a copy of official notice, and there's a copy of the Open Meetings Act on the north wall of the legislative chambers if anybody wants to know. And we'll begin with roll call.
Wade. Festerson.
Here.
McNally.
Here.
Rogers.
Here.
Weiss. Jones. Wilkin.
Here.
King. Espinoza.
We will move to item 2, which is approval of the minutes from the last meeting. Is there a motion to approve?
So moved.
Motion by McNally, is a second.
Second.
Second by Wade. Roll call.
Yes.
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 We'll move on to the action items. I would ask that item R be removed to be done separately. And if there's nothing else that needs to be removed, I'd ask for a motion to approve the action items minus item R. Motion by Wade, is there a second?
Second.
Second by Wilkin. Roll call. Wilkin.
Yes.
Yes. Is there a motion to approve item R?
So moved.
Motion by Wilkins, a second.
Second.
Second by Festerson. Roll call. Abstain. For the record, I need to abstain because I sit on that board. We'll move now to presentations, and item A is the accreditation update.
Good morning. My name is
Morning.
Catherine Plumley, and I'm the accreditation coordinator at Douglas County Health Department. And I'll just be giving you all an accreditation overview this morning. If you're on the Health Equity Committee, you might have already seen this. I'm using the same slides, just slightly altered. So we'll go over a little bit of accreditation, what it is, where we are in the journey to accreditation, areas for improvement, and areas of focus. So you all know that accreditation is in accordance with and guided by the 10 Essential Public Health Services and the Foundational Public Health Services. But what is it really? So it is a set of standards and measures. There are 10 measures and 20 standards, 75 measures, 10 domains, excuse me. But all of that leads to 206 documents that we had to prepare and submit to FAB, the Public Health Accrediting Board, for them to assess if we are exemplifying public health best practice. And so I want to quickly show you all what that looks like. So if we come here, this is the FAB Standards and Measures. It's a big old book, 315 pages long, full of standards and measures. And you can see where all the 10 domains are kind of color-coded and correspond directly with the 10 essential public health services. And if we jump to a measure, we'll say 913, you can see that, this measure has a required documentation 1, but even within that, there's required elements A, required elements B. So they get real specific about what they want to see. And then even within this measure, there's 2 examples. So that's how we get from 10 domains to 206 examples really quickly. And then this measure, 913, even has another required documentation and 2 examples for that. So that just kind of gives you an idea of the guidance that we are following. So ultimately, these are the 10 domains. I'm not going to read them all here, but I do want to point out that health equity is listed here in Domain 5, but it's not only in Domain 5. Health equity really is centered. It's centered in the 10 essential public health services. It's centered in the foundational public health services, and it's centered throughout all of the domains and measures for accreditation. So where are we? You'll recall that we submitted those 206 documents back in March. And so now we're in the review stage. So let's dive into that a little bit. What that means is we submitted all of those 206 documents were assessed based on if we were fully demonstrating to not demonstrating. Some of those were returned to us. If they were slightly or not demonstrating, they were returned and we were given another opportunity to explain ourselves. Some comments stated, oh, you're only slightly meeting this. Tell us a little bit more, Some were, tell us a little bit more or submit a new example. And then some were maybe, this ain't cutting it, submit a new example. So we had 45 days to respond with additional documentation. We did that. And so now they are reviewing that additional documentation. That's kind of where we are in the process. What comes next is a site visit. So it will be hybrid. So there will be some virtual and some in person. And that really is for a chance for them to see, what we're doing, validate and verify what we submitted. They may ask for additional documentation again at that time. And this is where some of you all might be called on to have interviews with them, talk with FAB a little bit about what we do at the health department. And so that will, the in-person visit, they'll come, they'll tour our facilities, they'll talk to staff, they'll talk to the director. And then really, like, it'll be a time for us to shine and the last opportunity for us to submit any more evidence before they create their report. So we'll have 2 days to submit more evidence, then the site visit team will write the site visit report. This report, they will comment on every single measure, whether good or bad. So if there are areas of excellence, they may highlight that. If there are areas for improvement, they'll definitely highlight that. Even if we are mostly or fully demonstrating a measure, but there's still more we could do, so like maybe it passes the check, they might still highlight that as here's an area to improve. Once they complete that report, they will send it to us and to the accreditation committee at the same time. So we will see what the accreditation committee sees. And then the accreditation committee will make their decision based on that report. At this point in time, the accreditation committee has 2 things they can do. They can either accredit us or they can give us an ACAR, an accreditation committee action requirement. And that is a list of items that, you know, maybe we're still not meeting, we're still not there. So they're going to give us some extra time to work on that, up to 12 months. That doesn't mean we have to take the entire 12 months. If we're able to get something done in 1 month, 3 months, 6 months, we can hit submit whenever we feel like we're ready. I don't see the ACAR as a bad thing. It's just more opportunity for continuous quality improvement, which is what we're going to be doing anyway, even if we get accredited. I do want to say you can get accredited and not be meeting some of the measures. I don't know what that threshold is, so I don't know if it's like you can meet 5 or not meet 5 or less and still get accredited, but 6 or more, you're going to get an ACAR. I don't know that. But you can, you know, not be meeting, get accredited, and then those are the measures you're going to focus on in that first year and report out in your annual report. If we get an ACAR, it's a similar process. We'll work on those items, we'll submit, there's a review by the site visit team, they send it to the accreditation committee, then the accreditation committee will make another decision, which is either to accredit or not accredit. Not accredit is very rare. FAB's goal is to support and have folks do continuous quality improvement, and they want you to succeed. Once you get accredited, then this timeline kind of expands. You'll continue to focus on certain measures each year, reporting that out in your annual report. You're accredited for 5 years. And then after 5 years, you start working on your reaccreditation. And reaccreditation, it's less like providing examples and more providing narratives on how you have maintained the standards. So this is just a list. I'm not going to go through this in detail, but this is a list of what we got returned to us originally. And I just mentioned that because there were 4 items we were not able to respond to during that reopen request. And these were the 2 measures that those pertained to. So one was implement the performance management system. I'll say, you know, we do have a performance management system. We just kind of got out of the habit of keeping it on track during COVID, and we maybe weren't meeting it with as much rigor as it required. Remember those elements A, elements B? We were maybe hitting element A and B and not hitting C, you know, so that's why the comment was, they commented on it. But I can say we are working on this. We will have something to show them by the time of the site visit. The second one is implement quality improvement projects. And again, it wasn't that we weren't doing quality improvement projects, it's that we weren't doing them with enough rigor. And so now we have updated our template here. it's really tiny. You don't have to read it. I'm just showing the point that these highlights that we've added to the template, these are element A, element B, element C. So if you answer these questions, we're guaranteed that this is going to be meeting the standard. And we already have QI projects, one's completed, one's underway, so we'll have QI projects available to turn in at the site visit. Next, we have areas of focus. So this, again, was created for the Health Equity Committee, but I think it's still good areas of focus to mention. One is our access assessment. So we used the CHA, the Community Health Needs Assessment, as our evidence. And really, the CHA is a report out of the data. And what this measure is requiring is a more thorough review, conclusions drawn. So they want more of a discussion-based assessment. And so that is something with our CHA data that we have right now that we can improve upon moving forward with this iteration. The second area of focus is policy. So the measure states that we have a department-wide policy declaration or initiative around DEI and anti-racism. We do have that. We have the Racism as a Public Health Crisis declaration. But in addition to that, we're going to continue to do more thorough policy review. We have initiated a policy review committee, and we'll be looking and reviewing policies with an equity lens. Lastly is our strategic plan. So just adopt a department-wide strategic plan. We had one. This isn't stuff we didn't have or got comments on necessarily, but just saying that we are in the season of strategic planning again. We've been doing vision to reality work, so we have some vision of values, and all of that is going to lead into the strategic planning process, and discussions have already begun on the timeline for that. So that's all I have. Here's a list of the resources that I kind of stuck in throughout the presentation, but that's all I got. Any questions?
Sorry. Regarding the standards, how does the Board of Health measure up in terms of the requirements from FAB?
So we didn't get, there's a few measures that pertain to the board. It was mostly about how do you orient or onboard new members, how are they made aware, and there's a manual I think Jeannie put together, and so we didn't get any comments back on that, which means it was either mostly or fully demonstrating. There were also some about communication, like how often we communicate. So we mentioned the monthly board meetings. We share the minutes via email with all the staff, so the staff is made aware, that sort of thing. So y'all are doing great. Keep doing what you're doing.
Yes, ma'am. You said, I thought I heard you say, so when you get accredited, you get accredited for 5 years,
Mm-hmm.
and then you said you start right back after that for the next accreditation. Did I hear you say that?
Mm-hmm. And I said after 5 years, really, like in year 4, you should start prepping and spending that year 5 really collecting the documentation so that you can just kind of go right into the accreditation process.
But pretty much it sounds like once you get accredited, there's somebody who's going to pay full-time attention to it. It's kind of like a joint commission visit. You almost got to be continuously doing it. In the 4th year, you just assimilate everything and make sure you're prepared.
Exactly.
Okay.
So the goal is to make accreditation part of the culture so that we're always working on it. We're always thinking, oh, if I'm doing a project that could meet measure 913, let's remember that, instead of, okay, we got accredited, we forget about it in 5 years, and 5 years from now, we're scrambling to find examples again. My goal is to keep it always on mind and just keep gathering documentation throughout the 5 years so that when it comes time to submit, we're not scrambling. We'll already know what we're doing.
So you basically almost take charge of the policy manual internally. That's basically, because this will eventually work its way into that manual.
Yes, I will say as the accreditation coordinator, I am on the policy review committee, and so similarly, we're going to try to get into a rhythm of, because many policies state this is to be reviewed yearly or every 2 years, but I think COVID just got us out of the habit of a lot of maintenance. And so really we're going to try to start to, develop those healthy practices, get in a rhythm, and then stay on track with policies, reviews, and feed into the rest of accreditation as well.
Okay. I was curious. I saw you shake your head. I don't know if I meant it literally, but basically, you're in the room with the policy. So basically, it is the accreditation. Some of this will become embedded in the culture. It will become a functional day thing. So, okay, all right. That's all I have. Thank you.
Thank you.
Appreciate it. Item B, the Public Health Foundation update.
Good morning.
Good morning.
You'll notice that our agenda is a little bit out of its usual order, and I'm going to explain that a little bit later. So if that's making your brain itch a little bit, just know that I will be talking a little bit more about that later. Okay, so Chris brought this up last week, but it's not a new conversation. In fact, this is an item that has been on our strategic plan since it was written back in 2018, 2019. And so, right now what we're facing is kind of a fiscal environment where there are a lot of unknowns, if you will, and we are certainly not the only jurisdiction that is experiencing that. There are many, many health departments around the country that are in similar situations, just not quite sure what the coming years are going to bring in terms of support for public health, especially through funding. And so many health departments around the country are looking at similar ideas in terms of diversifying how they support their departments. So typically, what we're going to see is really what I'm talking about here today. This seems to be a fairly popular idea that is being discussed a lot more. And again, a lot of this stems from how we've been funded historically. And again, this is very similar to most health departments. So our biggest chunk of money, if you will, is really the grants that we are able to bring in. Those grants come from a variety of sources. Many of them are federal grants or federal pass-through through the state. There are some state grants that are basically set up through legislation at the state level. There are even local level grants that we apply for and get. For example, the money that we have been able to get from the Sherwood Foundation to support our STI work. So lots of different pots out there that we are able to apply to and hopefully draw funding from. After that, we have our county taxes that basically, any function of government gets some piece of the county taxes, and we get a certain amount of that, which really goes for supporting mostly salary and benefits and a little bit of operations. And then at Douglas County Health Department, we do have some limited revenue from fees. So we are able to charge fees for permits and things like that through environmental health type inspections. And so those funds typically go into our general fund, specifically the health department's general fund. And so we're able to use that to support some of our our people and programs as well. So that is kind of historically what funding has looked like here at the health department. And again, very similar to what you would see in other places. The mission of what I am talking about here today is really to give us an extra stream of income, if you will, or an extra pot of money. One of the things that we struggle with especially those grants is that they are usually very tightly earmarked for a very specific purpose. So for instance, I may have, a grant that is supporting, let's say, our vaccines for children. And let's say we have a new threat that has arrived in our population, something like, I don't know, Mpox. How do we pay for Mpox vaccine or response with our immunization funding if our immunization funding is very tightly earmarked for a very specific population? That's very common for all grants. So typically what you're going to see is that whoever is providing that grant is going to say, you can spend your money on X, Y, and Z, and it's usually very specific to a program, and you are not able to spend those funds on other things. So if you have other things that are happening in your community, as we often do, we have needs that just arise. We really struggle to find ways to pay for that. And so one of the things that this foundation that I'm going to be talking about would allow us to do would be to offset immediate public health community emergency response needs. So a great example of this would be our incredible community tuberculosis response that we had last fall in November. Just a very quick refresher on that. We had an individual that exposed a number of children in a daycare setting to active tuberculosis. It spurred really a huge response that involved about 600 kids needing to be tested for tuberculosis. That is an extremely heavy lift, a lot of moving parts in order to get that to happen. We were so lucky to have such a good partnership with Children's and just feel very, very lucky that they were willing to jump in and help. But the question came up very early on, who's going to be paying for chest x-rays? Who's going to be paying for the PPD tests? Who's going to be paying for, all of these different moving parts for our outside agency? And actually, we ask those questions internally a lot too. Typically, when something like this happens, we are asking our community partners to fund kind of their own part of the response, and then we're playing Tetris internally to figure out how to cover our side of things. Oftentimes we have things like overtime that we're going to end up having to pay when we're in a public health emergency. And that has never really sat right. And I think that while we are not able to completely cover perhaps an agency's response work, it would be really nice if we had a way to offset some of those expenses. I think that would go a long way toward even more robust responses in the future. This fund could also go towards special projects and programs. So for instance, you have a new need that has perhaps appeared in a very specific population. You don't have grant funds to really help. This would be a place where perhaps we could draw from to take care of that, very limited need or special project as our community needs it. So a lot of times what happens is we know there's a need out there. We know that there would be a great partnership. It wouldn't be, perhaps a huge amount of money, but we don't have that money. And so oftentimes we kind of sit and wait for a funding opportunity to come around. So this would allow us to be more agile when we are responding to the community's issues. This also would perhaps help with our public health infrastructure and pipeline. Something that we talk about a whole lot in our department and with our partners is the need to have a department that really reflects our community. And there are challenges with getting people into the public health pipeline who want to work in public health, who have education in public health, who understand it, really who even know about it, and know really what it is. And so to build a pipeline, this would allow us to for instance, go into schools, maybe at the middle school level and talk about some of the cool work that public health does and start to build some of that interest. This would be perhaps a way that we could help fund those sorts of efforts. Supplemental staff development, so if we have staff who perhaps need a skill, they need to beef up a skill in order to do their work well, or there is a really great conference, but we don't have much of a travel budget. This could be supplemental for helping to develop our staff. We often have building needs. Those come up really, really frequently. We have a lot of building needs. This could also help with that if necessary. Support for community work. So I could even, if this foundation is robust, I can imagine being able to create and award mini grants to other partners in our community who are doing great public health work that perhaps we don't have the capacity to do, and we don't need to duplicate and reinvent the wheel, but perhaps if they just had a bit of a boost, they would be able to do more work. That could be a potential. And then, of course, cushioning uncertainty in other funding sources. So, every election cycle, we're holding our breath a little bit. Every time we have different policies that are coming up in legislation or legislative session, we're kind of holding our breath a little bit because we don't know, what's going to happen. And it certainly doesn't take away the need to advocate for public health funding at all of those other levels, but this would perhaps provide just a little bit of a cushion when we have some of those uncertainties, or if we have to change funding sources due to some kind of a change. Sometimes we find out last minute that we won't be getting funding in a certain area, so this would allow us to perhaps fill the gap as we go to look at more sustainable funding. So the strategy to address all of this is to establish a 501c3 for Douglas County Health Department. Again, this has been discussed off and on, I think, for several years now. This was part of our 2019 strategic plan. Of course, COVID happened, so this was probably not top of the mind work during that, and we are actually just getting ready to rewrite our strategic plan, or to update our strategic plan, and I imagine that this work will remain an important piece of that. Again, it's becoming more common in public health settings. Not every health department has this, but there are other health departments, even in Nebraska, that do. And the big thing here is that it's really going to give us some of that flexibility that would be very helpful for us in public health. There are a few questions that we need to answer as we're going forward. First of all, we will want to determine what kind of a governance structure we want around the 501c3. This is done in different ways in different places. For instance, our neighbors to the north, Elkhorn-Logan Valley Health Department is one of those that has a foundation, and their governance structure mirrors their health department structure. So essentially, their board is the governing structure for their foundation. So that is an option. They have bylaws. They have all of those usual documents that are specific to that foundation. They conduct the business separately, but it's the exact same people. They just put on a different hat, essentially. In other places, such as Lynn County, Iowa, they have a separate board. So they're basically, the health department director serves as the president. However, that board is populated by a board member, I think maybe another health department individual, and then some citizens from the community who are interested in that work. So that's an option. There are likely other options out there, and I am actively researching that right now. We also have to ask what approvals are necessary. My understanding at this time is that we can go ahead and move forward with this if it's something that the board is okay with. And then, of course, we want to ask about long-term sustainability, so that those are, I think, strategic questions that will come along the way in terms of fundraising, how to, if the foundation grows big enough, does it need a separate executive director? Does it, I think those are all questions that will be coming that we'll need to ask and probably discuss in more depth, hopefully here as a board. A little bit about where we are currently in this process. So I have been actively reaching out. Thank goodness for Nonprofit Association of the Midlands. They are a wealth of information, obviously, about nonprofits, and they have been extremely responsive to all of my very probably seemingly naive questions over the past year and a half, and I'm so grateful for them to always point me in the right direction. So I do know that we need to hire outside legal help and CPA help in terms of setting up like all of the paperwork that has to happen to actually stand up a 501c3 and be recognized there, and then to have all of the accounting components in place. So I am not a nonprofit person. I have been a government person my entire life. I work with nonprofits on a daily basis, but I certainly need to learn more. And so I am actively learning, reading, doing webinars, doing all of those things, having conversations with community partners who have done this to become more knowledgeable so that we are on good footing. So funding for that legal and CPA work is definitely something that we had to look into. We're very lucky that our infrastructure grant that we were awarded from the CDC has authorized us to use funding specifically for this, because it truly is something that would improve our infrastructure as a health department. So we've already reached out to the program officer, asked those questions. All it takes on that side is essentially changing, and resubmitting a budget narrative, which is a very minimal administrative piece that we do all the time. So that piece, really, there isn't a whole lot that we have to do around that. And then, again, we just have to determine what the appropriate framework looks like here in Douglas County, whether that's the board is the board is the board, or there's a separate board with board representation, how we want that to look. And so those are kind of the big things that we are exploring at this time. Again, I'm reaching out to other health departments as I find, more that have foundations or that are having foundations over time to see how they've done it. We also have a foundation already at the health center, so they already have one set up. It's been there for like 30 years. That's a little bit more challenging to get information on the initial setup because those who did that are no longer there. But they do have a foundation that they successfully manage there. So that is also something that we can look into a little bit more in terms of how they operate that. So the next steps are to hire that attorney and CPA assistant. So right now I have reached out to NAM to find out who are the attorneys, law firms, CPAs who have done this kind of work successfully in the past. I have gotten a list, so that's fantastic. So right now I'm just wading through kind of all of the information there so that we can put out some queries in terms of what this is going to cost us, what a contract would look like, and those sorts of things. Of course, there is a whole lot of paperwork that has to happen. That's why we hired the attorney, so that we don't have to try to wade through all of that paperwork successfully on our own. We'll need to establish banking, so basically you just got to go open a bank account somewhere, and then establish that governance structure, bylaws, those sorts of things, and then we should be up, running, and ready to go. So that is a very quick down and dirty about what we've been thinking and where we've gone, and I would love to hear any questions you might have.
Go ahead.
Thanks, Lindsay, for that overview, and I can see why this would be a helpful tool to your work and responding to the unforeseen, which is kind of the happens pretty much every week in your business, right?
It seems to more and more.
It happens on the city side and the county side too when we talk about disaster and storms and some of the things we've experienced recently too. And that's actually a first question I had before I kind of have a few questions about the structure.
Sure.
When you do experience an unexpected public health emergency and you're scrambling to find the resources to respond, are you eligible for federal reimbursement or disaster recovery like cities and counties are?
We could be in some circumstances, but it really depends on the nature of the emergency. It depends on what our actual work was. So there are times that our work is reimbursable through like FEMA, if you will. But you think of something that we're responding to, such as MPOX. That's not something that we would be getting, FEMA reimbursement for. Oftentimes we'll have CDC funding that comes available, but it's usually a huge lag between when we need to actually be responding, which is, right away, and then, a year down the line when they actually give us funding. So in that example where we had cases of MPOX that were occurring in the community, we were actively investigating them. We were actively working with our hospital partners. We were, trying to find appropriate places for people to be while they were waiting for lab results about whether they had MPOX or it was something else, which brings up costs about, well, if you have to lodge somebody, for instance, if you have a homeless individual, who's going to pay that fee? Who's going to cover this? Who's going to cover that? We didn't get funding for that response for a year. It was like 11 months, wasn't it? It was quite some time, and by then the response was, the acute phase of the response was effectively over. At that point, we were still campaigning to get information out there and hopefully get people to vaccinate against it. But in terms of that acute work, I mean, we literally were like, relying on the kindness of our partners to help us out. We did have just a very minimal amount of funding. We were able to kind of pull over from, I think, COVID vaccines because our project officer on that was kind enough to let us do that. But it's a huge amount of legwork even to find just minimal funding to run with a response, which is a detriment to the community because it's a lot of manpower to, be calling program officers and be, working with fiscal and doing this and doing that, when really those efforts would be much better spent focusing on the response work itself. And so
you are eligible, it's just that it is a lot of legwork and it happens on the back end rather than the front end.
Right, exactly right. And it just totally depends on the response. So for COVID, we did get FEMA reimbursement for some of our COVID work. It was extremely intensive to do all of the kind of the paperwork involved for FEMA. And anybody in government who's ever worked with FEMA will know that
We're still working on the May floods, let alone the tornado
Yes.
or the recent windstorm. So, yeah,
I met with Whitney earlier this week, and she was telling me about how much fun all of that has been. So
Okay.
I understand.
And then I think you're right to really delve into thoughtfulness around governance and structure and making sure it's consistent with what we're doing here and consistent with how this board is directing your work and you as executive director. And that needs to be seamless, I think, when we talk about a separate structure here. And also responsible and transparent as a subset, really, of government that this could be. Then I'm interested in the funder question, too, which we can talk about further offline.
Sure.
But to your point, I think my experience with funders is they are very directed towards certain things and funding certain causes or certain issues rather than just here's some baseline funding in case you need it.
Yep.
But that would be a challenge potentially in this scenario, but doesn't mean it shouldn't be attempted. And then I actually was a member of the Douglas County Health Foundation about 20 years ago when it started, and I can tell you that if you have questions about how that was set up or how they did it, Claire Duda would be a great resource for you.
Wonderful. I appreciate that. I'll reach out.
Anybody else?
So I guess at the beginning of the presentation, before we got into the new stuff, there was you were talking about for environmental health, the new fee structure that had just got passed, and just I guess a comment observation on that. I mean, it was a pretty minimal increase, I think, on those fees, especially compared to inflation, where that has been recently. And I saw there was a lot of former fees that had been removed or gone away. I didn't see any new ones that had been put on. But do you feel like with that fee structure, at least with what has been budgeted, you feel good about that we're still, by removing some of those, that we're still covered on what we budgeted those for?
So for now, yes. However, I will also tell you that there are other fees that that we are planning to instate that you'll be hearing about. Before we do that, though, we want to have good conversations with the people who are going to be impacted by those fees. So for example, and I'm glad Adam's in the room in case I blunder this horribly, but historically, we have not charged nonprofit vendors, and we have not charged our school systems for inspections, and those are actually a pretty big chunk of inspections that we do. Most places do charge an inspection fee or a permitting fee for those types of organizations, and so before we just put something down and start charging people, we really want to have a conversation with them first. So we are in the process of setting those up. We have a conversation with our nonprofit partners, nonprofit vendors or restaurant owners in the community. I think it's next week, isn't it? It's coming up September 30th, and then I'm working with ESU 3 to set up a similar conversation for our school superintendents. So those conversations are happening. It's going to be a couple months before you see things like that. But we are also, in addition to considering this foundation, we are also looking at our fee structures. We are looking at where have we left fees on the table, essentially. That other health departments perhaps have historically collected. We're looking at, we have just implemented in the past year or so a new electronic health record system. That's going to allow us to start billing insurance for some of the clinical work that we do. It won't be a huge number, but certainly that is something that we will at least have the capacity to do. And there's some other conversations happening in the community about, what things can be billed for and things like that. So we are not only looking at this as a means of diversification, we're also looking at our other business practices to see how we can do a better job.
Okay, thanks.
Yeah, you bet.
Go ahead.
How can the Board of Health assist you in this process?
I think the most important thing that the Board of Health can help with is really helping to determine what that governance structure should look like, to determine whether you want to be the ones who, essentially you finish a Board of Health meeting, you adjourn, now you put on your foundation hat and you basically start a new meeting that's specifically for the foundation, and you are the board that oversees that foundation, or if you would be more comfortable with having it be a separate board. Perhaps one or more of you are members on that board or representatives on that board, so there is still board oversight, but there are other individuals outside of this board that are involved, so perhaps some of those funders that we really want to have involvement from, perhaps they have representation on that board. It can look a lot of different ways, and so really helping to be thoughtful and mindful and set this up in a way that will be successful, and also to Pete's comment about being transparent, ensuring that what we're doing is with the community's best interests in mind. I would really love that assistance.
Yeah, I would build on that and say, I don't know, I was in a meeting this term, got up, and it's always stuck with me. But even though you're saying some boards have done that, there's a term called piercing the corporate veil. And I don't know if there's a certain number of board members you can have, or if you can really have that mirror image, but I'd be interested because that was a nonprofit board. This is like a public board, and you may not have that. But I would say too, that's why I wanted this conversation today for a lot of reasons, timing-wise. It's timing correctly because tonight is the third Truth and Taxation meeting, and I'm curious to see what the feel of that crowd is.
Yeah.
Because I don't know if what happened at the state will give any immediate relief. My understanding is that, well, yeah, you've heard certain articles, but my understanding is that that fund, the money that they usually give the tax relief out of, people had to apply. And when everybody applied, well, not everybody applied, which made that pot of money more, so it spread more. Now, everybody gets it off the top, so that application is gonna be less, so I'm curious to see how people respond to that. The timing will make it good, because, even though the health center has that separate foundation, the Board of Commissioners also serves as the Board of Trustees for the health center, so there's a discussion you probably have to happen there, and I'll try to work that through, but I do know there's a part of me that the foundation board, how we do it, could definitely have some of us, but may need a different mix, because
Sure.
you're probably gonna need a degree of rainmakers on there.
Yeah.
And that's gonna be the key piece, and I think there's some very strategic people out there that are definitely interested in public health enough, and the freedom that it would give it, which would get us there. But John brought this up too, and I think the board's role in this could be good, because I think it's good that you alluded to it, because I had it as a note, but I think, particularly in your role with the restaurants, I think you need to just put it out there with them very seriously, that the state's put us in a situation where we were able to kind of subsidize that a little bit, and that's a whole new ball game. I mean, we still don't know as a board how that plays out to everybody else, and how do you get around that, because the only groups that are exempt from it are public safety to some degree. So you got some critical elements of the operation that are going to be at this zero cap unless they follow through on the fact of just getting us up to 3%, which hopefully they're gonna push and get there. So it's a whole new ball game for the nonprofits, the schools, and everything else. And so those are definitely the pieces that I think are that we need to keep an eye out for. So tonight, particularly as a board, if you've got any interest if you're interested in sitting through a 3-hour meeting of some intense, I wouldn't say hate, but intense feedback, it would be a curious thing for you to watch. So, but other than that, my hope is, I'm gonna see what happens tonight, but I think the next stage is just put me before the board and put it on the radar, and going from there and see.
When you say board, you mean county board?
Yeah.
You got it.
I'm gonna see if it can be done in executive session, but it was done public here, but it's a whole different thing. But
Sure.
we'll
Let me
see
know.
from there. But other than that, yeah, it's the right timing, and then we'll see where it goes from there.
It's exciting.
Yeah. All right. If there's no other questions, go from there. Move right into you and your report.
That's why I didn't move. I knew I was just going to have to come right back up. All right. So I told you that I would talk a little bit about why we flipped our agenda a little bit, and I'm hoping that was okay with everybody. I kind of just made an executive decision to do that. This stems from a little bit of our V2R work and something that happened at our last board meeting. So if you will remember, we have gone back and kind of redefined our core values, the first of which is people first, which I talked about quite a bit last month. We also had an individual who had come for basically her 15 years of service recognition, and unbeknownst to me, she needed to leave, and we had also flipped our agenda around in some different ways for that meeting, and unfortunately she had to leave before we were able to do that recognition, which is not a very people first thing to do.
And I'll take blame for that. I didn't know she was out there waiting for that.
It's all good. I didn't know either. And so I wanted to just talk to you about a couple of things that I kind of just made the decision to do. Hopefully you'll be okay with it. I think you will. Just to make sure that in this setting, we are really honoring that core value of people first. So often we have guests that are coming in to present. So you'll notice that Catherine has already left. She had a commitment at 9 o'clock this morning. And so I made the decision to put her first on the agenda following the consent agenda so that we could honor that time. And I would really like any time that we are having guests come in to present, or we're doing coins or some kind of recognition for people, that we are putting that first and foremost on our agenda. It's kind of bunkered there. Now, I'm not saying there isn't room to move that. If that guest says, I can't get there till 9 o'clock, of course, I will happily change things around and put them later on the agenda. But I do want to honor and respect people's time. And so I've just told Heather that that's number one on our agenda going forward instead of my report, because y'all can wait on my report. So that was the first thing. And then I have also empowered Ms. Heather and my chiefs to speak up if something like that needs to happen within a meeting. So if something has come up where somebody, I don't know, you don't know, they need to leave, perhaps that got missed somehow, or something's happening where we need to change, I've empowered them to go ahead and just speak up in the meeting and say, hey, can we pause and put this person next, or whatever we need to do. And that way, they're not relying on me to maybe have my phone in hand, or to hear somebody whispering behind me, hey, we need this person to go next. So I would like them to be able to just be able to say, oh, we need to have this person go next, or whatever needs to happen, so that we can again honor those people going forward. So that's the explanation for why the agenda looked a little bit different, and we started with presentations this time. So
Dr. Hughes, before
Yeah.
you go there, that's no deal, but this is how I would like it to go.
sure,
Don't just blurt out. If there's an issue that comes up like that, just slip me a note,
got it.
and then I will make that arrangement.
Notes to Chris.
So,
Is that
okay.
good? Okay. Excellent.
I have one comment on that too. I'm supportive of that as well, and I think we always try to accommodate that in our city council meetings also, for example. But I will also say it's important to be thoughtful about that up front when we're crafting the agendas, because
Agreed.
people do see a public agenda, and oftentimes are timing their participation based on how that agenda looks.
Absolutely.
So if we get here on a certain day and just move it all around, that's also could cause issues in that respect too. So to the extent possible, I would just say, give that some thoughtfulness up front and have it be represented in our agenda that month.
Agreed.
But certainly there can be flexibility along the way.
And to that comment, I would take the language that we were advised legal counsel wise. It's at the bottom of the county board agenda somewhere, and it states that items could be moved, so
Excellent.
they're just aware.
Yep, I remember
You
that.
would try not to, but I
Could we
would
add
I would
that?
add that onto the agenda. So
Yeah, that's great. Wonderful. Okay, so other business. I'm very, very excited to tell you that our new Chief of Environmental Health is on board, and he is here today, Mr. Eric Bradley. We are thrilled that he's here. He comes from Iowa and has a lot of experience in environmental health, emergency response. He's just got a really fantastic background. And I'm so excited because he's actually already, I think day one, day two, he was already reading through the ordinances that need updated. He's looking at the standards. He's looking at all of I think the climate action plan, just a whole lot of different things. He's been, I think, out with his team already to see some things in the community. He's super engaged, and so we welcome Eric, and we're so thrilled to have him on board. Welcome.
what county in Iowa by chance?
Which county was it?
Lynn County.
Oh, it was Lynn.
Scott County before that.
Lynn. Did you, were you there when Linda Langston was there?
I was not, but she was actually on, we had a foundation she was on.
She's on the foundation. Oh, that'll be a source of information I can get some stuff on. Okay.
Yep.
That's good.
All right. I covered our change there with the agenda. So Public Health Wins is a survey that I think is it annual or every couple years? Is it every 2 years maybe that it goes out? It's a national survey that comes out and essentially is a workforce survey. So it goes out to all of the public health workforce. And it's really looking at a number of different variables to gauge kind of how healthy the workforce is and what their needs are and what gaps and successes there are. So that survey just came out, and we are encouraging our employees to fill that out. So if you are a health department person and you're on the call, this is another plug for getting the PHWin survey done. We have to have 80% response rate, which is huge, in order to get good data back. And so we are going to be just continuing to encourage that over the coming weeks, and hopefully we will get results that we can actually share with you, the board. Negotiations with the Health Department Employees Association should be coming up soon. We're starting to just start to have some preliminary meetings around those, so just wanted to let you know that that contract is up for negotiation, and those conversations, while we haven't had a sit down with attorneys yet, certainly Justin and I have sat down and started talking about what that's going to look like, and I'll have lots more information for you probably to come on that, but I wanted to let you know that it is coming. A very exciting other piece of progress that we have is our strategic plan contract you approved last month, and we have actually gotten the contractor on the ground already to come and meet our leadership. So she was able to come to our last management team meeting and just kind of talk to our management team about strategic planning and what that looks like. There is absolutely a board component to the strategic plan. And so I also wanted to just prepare you that we'll have some more communication about that coming, but I'm very happy to report that over the next 6 months or so, we'll be working on our strategic plan. My goal for that strategic plan, by the way, is for it to be very action-oriented and very targeted, should we say. So I think our last one had amazing information in it. It was just very large and very difficult to decide what we wanted to do first, next, what steps we needed to take. And so this one's just going to be a little bit more consolidated, and it'll be very action-oriented. But I'm very much looking forward to that work, and you'll be contacted soon about your involvement on that. One big announcement that I wanted to make to you this morning is that I made the decision to move our FEMUR program from one division to another division. So FEMUR is the Fetal Infant Mortality Review program, and connected to that is the Baby Blossoms Collaborative. That will be moving from our Community Health Clinic Nutrition Services division to our Health Equity division. Part of that is just knowing that there is a ginormous, can I use that word professionally, a ginormous growing gap between, really in that disparity between deaths occurring in the white population and the Black population. And so health equity just makes a lot of sense for that to be where that program goes. They also have some expertise in that division that I think will be helpful. And it's really going to give us some great opportunities to grow some of the other work that's happening in Leah's division. So we're pretty excited to see the changes coming from that, but I wanted to let you know, since that is a pretty big move, and we do have quite a few community partners that are engaged in that work. And I believe that's all I have for updates for you from the department. Do you have any other questions for me today?
I'll just note that so if you all next week on the board meeting, that will be the resolution for Black Infant Mortality Health Month. So
Great.
For October. So just if anybody wants to, be there.
Excellent.
Yep.
Good morning, Doctor. Thank you for all the information that was given today. I just want to go back to the action items and the CDC grants that are coming for the OD2A.
Okay.
I did see that you have a variety of community partners working on that. I'm just kind of wondering, how are we going to measure their success, being that they're giving these grants to work on our overdose action plans? And will we ever hear a presentation from these community partners on how they're using these funds to support that action plan?
That's a great question. I would love to invite Leah up to answer that if you don't mind.
Good morning. Great question. So we've actually, one of the contractors that I believe is on here, University of Michigan, is going to be our evaluation work. So they are actually creating reports that we will have, I believe it's monthly reports from our contractors that we're working with. But we have set items for them to accomplish throughout the funding period that we have. But I know there's some of them that would love to come and talk about the work they're doing. We're really excited. It took us a little bit to get the OD2A grant up and moving just because of some budget and CDC issues. As you all know, sometimes takes a little bit longer to get moving. But we are now full steam ahead, and there is so much happening. I cannot wait to share with you all the stuff that's been moving forward with that. So happy to have those scheduled maybe in some of the upcoming months. Yeah.
Anybody else? Okay, appreciate it, Doctor.
All right, so the last thing that's on the agenda is also me. Sorry, you guys have to listen to me talk so much today. I just also wanted to do a really quick, brief discussion on our value or our vision to reality work, which is that values work. So last month we talked about people first. So what's happening in the department, I'm coming here to talk to you, but all of these conversations are happening at all of the levels of the health department as well. The goal, of course, is to really incorporate our values in and help to make those connections between what we do every day and that value that is hanging on the wall, right? And so last month was people first. This month is belonging. So our second core value that we decided on as a department is belonging. I think this makes such sense, given that we are the health department and our vision is really healthy people, everyone, everywhere. And we can't do that if we are not inclusive of everybody. Of course, that counts in our community. So we serve everyone. We don't care what your politics are. We don't care what you look like. We don't care what you believe. We take care of you. You matter, you count, and you belong. That also matters internally. So we want to build or an organization where people can come to work and know that they belong there, that they're truly accepted and cared for there. I'm really excited for that because I think that an organization that values people for who they are laying a great foundation just for great success, especially when you're an organization that is focused on people. This also is just another way for us to codify our commitment to equity. So obviously we stood up, health equity. We have our resolution with our 21 action steps, all very, very important work. I never want to be a box that gets checked. And so this is just another way for us to say we are committed to equity. We are committed to everyone in our community and ensuring that everyone has the opportunity to live healthy lives. So I am quite excited about our belonging value, and we will be talking about it for the rest of September, and then we'll be moving into another one, which I will discuss at our next Board of Health meeting. And that's it.
Okay.
All right.
All righty.
Thank you.
Thank you. Item 5, any questions from the boards on any of the reports?
I just would like a clarification on the health equity and planning. At the very bottom of the report, it showed their visual vision and then the mascot. Explain to me the mascot because I just didn't get that mascot.
Is it the Yeti?
Yes.
Like a little abominable
blue-
snowman guy? Yeah. Okay.
What is?
Here's the story there. So when we started our vision to reality work, I was tasked with standing up before the entire department and describing why I thought that determining our core values and our mission and purpose and all these things was so important. I am a metaphor person. I think in pictures. And so basically the explanation that I gave the department is, we as an organization we are on a journey, and we have this big, hairy, audacious goal, which is the Yeti, by the way. That's up. We've got this big old goal that's up on this mountaintop, and we as a group have to help each other get there. That is what we're trying to achieve. The core values are really kind of our agreement of how we're going to hike that journey together. And so I had this big, nice, long scenario that I laid out with my metaphor. So the V2R launch team for the department decided that they would like kind of a separate logo, if you will, to go with V2R, just so that it stands out a little bit, which ended up being mountains. One of the choices that employees got to vote on included the little Yeti guy. Everybody loved the Yeti guy. So even though he didn't get voted as the logo, everyone wanted to keep Barry the BHAG. And so now the Yeti is our mascot, and we love him very much.
Need some shirts. Okay.
I
There
have
no
a
que-
question.
Who is that?
Hi, this is Kiana on online. Was it mentioned that the infant mortality resolution would happen at the next board meeting or next week?
That resolution is happening at the county board meeting next week.
Okay, thank you.
Got it. All righty.
City council as well. Yeah.
City council as well. Seeing no further questions, the next meeting of the Board of Health will be October 16th here. And there is no need for the special administration meeting, so that will be canceled for next month. And if that's it, I'll entertain a motion to adjourn.
Wade,
Yes.
McNally, King, Festerson, Jones, Rogers, Espinoza, Wilkin, Weiss.